We invite questions after both the talks are over.
नहीं ऑन हो गए लाइव कर रहे हैं हाँ नहीं कोई इशू नहीं ठीक
A very good evening to all. First of all, congratulations to Team AOI for this wonderful initiative of monthly lecture series, and thanks for the opportunity. So we shall be discussing today a very interesting topic that Dr. Nipulam already alluded to. A very rewarding surgery. It's a very easy surgery, but the diagnosis remains difficult. And diagnosis is mostly done after the complications happen. So we should strive to do it at an early stage. Okay. So we shall be covering this topic under the following headings: brief surgical anatomy, parathyroid identification, hyperparathyroidism, parathyroidectomy, and parathyroidenoma are explained. So as we all know, parathyroid glands are two pairs of endocrine glands situated in close proximity to the thyroid gland. They are derived embryologically from the third and the fourth ventral pouch. The fourth ventral pouch forms the superior parathyroid, and the third ventral pouch forms the inferior parathyroid. They are very minute glands located in the neck, almost few millimeters, 5 to 3 into 1 mm, weighs between 10 to 78 milligram, and they secrete a hormone called parathormone, which is very important for calcium and phosphate homeostasis in the body. So dopamine, they have a very important role to play. So as ENTs, we are concerned with parathyroid preservation in thyroid surgeries in central leg dissections and for parathyroid excision in parathyroidectomy. Now central to both is parathyroid identification, because they are so minute and they can be confused with a myriad of structures like thyroid, fat, thyroid nodule can, small nodules can be like that, fat, lymph node, thymus gland. So accurate identification of parathyroid gland is critical during cervical procedures, both to remove abnormal gland and to preserve normal glands. Even in parathyroidectomy, we should remove the diseased parathyroid while preserving the normal parathyroid gland. So parathyroid preservation implies not only the structure preservation but also the vascularity preservation, because that is important for function. So as we said, the superior parathyroid is derived from ventral pouch 4. So it has a smaller area of descent. Okay, and the inferior parathyroids. Okay, so inferior parathyroids have a longer area of descent, right from the angle of mandible to the pericardium. So the superior parathyroid are more consistent in the position, whereas inferior parathyroids can have variable position, but even ectopic positions. So superior parathyroid mostly are found in the vicinity of inferior thyroid lamina, the inferior column, within 1 centimeter of that. Okay, in most of the cases, it can be found in the upper foot or behind the retropharyngeal or space also, because it is derived from the fourth pouch. Inferior parathyroid, as we said, can be arrested, the descent can be arrested at any stage, so they have more variable positions. So they can be in the lower thyroid pole, ectopic in the thymus gland, thyroid ligament, juxtathyroid, or ectopic locations. So based on these, there are these classifications which have been made, because parathyroid, as we've understood, thyroid surgery initially recurrent meningioma was considered the holy grail, but now we all identify the importance of parathyroid. So various classifications have been proposed. In the upper block, you can see this is the Bristoli classification, where they say first is the thymus gland. These are the various variations found in the inferior parathyroid gland. Then the second classification on the left shows various the parathyroid relation in relation to the thyroid gland, whereas the last one shows its relation to the vascularity of thyroid. This is slightly in detail. For the positive time, we will be not dealing with this in detail, but this has been classified. This has been classified so as to help us in identifying for which parathyroid condition we should do organ transplant. So we all understand there are two pairs usually, but at times we find supranumerary gland and rudimentary gland. Any parathyroid gland, in addition to the normal 4 glands weighing at least 5 milligrams, are known as supernumerary glands, and extra parathyroid glands less than 5 milligram are known as rudimentary or excessive. These rudimentary glands are normally found located next to the main parathyroid gland. These come important in context of hyperparathyroidism, parathyroid adenoma, and multiglandular disease, where we need to look for these. Coming to the landmarks for identification of parathyroid during surgery, recurrent pterygium nerve serves as a very important landmark. The inferior parathyroid is anterior to the plane of recurrent pterygium nerve, anterior to the coronal plane, whereas superior parathyroid gland lies deep to it. Another thing is even tuberculous buccal gland. Inferior will lie anterior to tuberculous buccal gland, inferior to tuberculous buccal gland, as well as superior to the tuberculous buccal gland. So that is why, and the vascularity at the side is very important. So if you can see, the vascularity is lateral. It goes from lateral to medial in parathyroid. So if we do capsular dissection of thyroid gland, we can avoid, damaging the vascularity of parathyroid glands. So in this diagram, you can see you should not, the primary region which has been marked should be left undissected to prevent disruption of laterally based vascular supply to parathyroid gland. So this is how we should dissect medial to the vascular supply and separate it gently from the thyroid surface to preserve its vascularity. So coming to just a recap of the operative technique which we should do to preserve the normal parathyroid gland is ligate inferior thyroid artery very close, the branch is not the main trunk anytime, because inferior thyroid artery is the main branch to both the parathyroids, inferior as well as superior. So the inferior thyroid artery, the main trunk should not be ligated. The branches should be ligated very close to the thyroid capsule. Direct cauterization of parathyroid should be avoided. Careful dissection of thyroid capsule, that is capsular dissection is a must to prevent injury to parathyroids and also the recurrent pterygium nerves. Gently moving away the parathyroids without causing tissue or vascular trauma. Function intact. Inspect thyroid after removal of tumor, we should do autotransplantation, any vascular cell to the bed. And so, as we discussed, there can be various ectopic locations of the parathyroid gland, and which should be sought after in multiglandular disease or in recurrent hyperparathyroidism, which as we shall see later. So, parathormone, as we understand, is responsible for calcium and phosphate homeostasis in the body. So, low concentration of calcium in the blood will lead to release of parathormone, leading activation of osteoclast and influx of calcium from bone, decreased loss of calcium in urine, and enhanced absorption of calcium from intestine, leading to increased concentration of calcium in the blood. Now, the various functional disorders like endocrine gland and hypoparathyroidism normally happens post-surgery when it has been inadvertently or deliberately removed. Hyperparathyroidism can be primary, secondary, or tertiary. Primary happens due to parathyroid proliferative disorder, when the parathyroid tissue is getting hyperplastic or there is adenoma or there is carcinoma. Secondary hyperparathyroidism happens due to chronic hypocalcemic condition, which leads to feedback activation and more secretion of PTH, parathormone, which happens in renal failure, gastrointestinal malabsorption, dietary rickets, and on various drug therapies like phenytoin, chemotherapy, and laxative. Tertiary hyperparathyroidism happens when, because of the chronic hypercalcemia, the parathyroid hyperplasia has become, and one of the nodules becomes autonomous, the development of hypercalcemia. So as we said, parathyroid proliferative disorders include hyperplasia, which can involve multiple glands. Adenoma normally involves one gland, but double adenomas also exist in 10 to 15% of patients, and carcinoma very rare fortunately. So they have primary hyperparathyroidism. The manifestations are very varied. They can range from subtle, non-specific manifestations to chronic and even life-threatening crisis can happen. Initially, 30 to 40% of patients are asymptomatic, and presentation can be very varied from non-specific to multi-system involvement to acute presentation. Now, it is a biochemical disease. It is diagnosed biochemically, it is treated and monitored biochemically. So there are various biochemical variants of primary hyperparathyroidism. The classic forms: elevated calcium, elevated PTH. Non-suppressed PTH condition, where you have elevated calcium but normal PTH. And normocalcemic primary hyperparathyroidism, where you have normal calcium and elevated PTH. The classical description of primary hyperparathyroidism we know is of stones, bones, moles, and groans. That is kidney stones, bony pains, then cyclic moans, and abdominal groans. So So various manifestations. But asymptomatic conditions, like initial presentation, you will find the patient will have very non-specific symptoms like fatigue, muscle pain, nausea, constipation, brain fog, etc. So please, if it is diagnosed early, then we can prevent the subsequent skeletal sequelae and the various multisystemic sequelae. So parathyroid crisis is a life-threatening emergency where the severe hypercalcemia leads to multi-organ failure, and emergency parathyroidectomy is advised. Until it is subjected to surgery, you can stabilize the patient with loop diuretics, intravenous bisphosphonate therapy, etc. Now, pediatric population, luckily, the hyperparathyroidism is rare as compared to adults, and there is a condition known as neonatal severe hyperparathyroidism, which happens due to mutation leading to absence of function of calcium-sensing receptors, and which presents in very early infancy, leading to failure to thrive. In pregnancy, if it is like diagnosed outside of pregnancy or planning to conceive, then the surgery should happen. And if it is diagnosed like during pregnancy, it can lead to fetal and maternal miscarriages and maternal morbidity. So it should be taken into account. Now, pre-operative workup includes proper history examination and biochemical investigations and imaging. Biochemical investigations, the most important investigations are calcium and parathormone. Along with that, you will need to have 24-hour urinary calcium to differentiate it from familial hypercalcemia. And alpha-phosphatase, vitamin D, urea create. And imaging, you should have ultrasound like 4D CT scan helps in localization. Sestomomy SPECT is very, very important in localization. And skeletal X-rays to understand the various skeletal sequelae. The pre-operative localization has helped in the surgical paradigm shift from initial foreground exploration to focused surgery. So the diagnosis is biochemical. This we have already talked about. So parathyroid imaging can help us in operative planning and execution, can identify ectopic and or supernumerary glands, is essential before consideration of minimally invasive focused parathyroidectomy, necessary for reoperative patients to focus surgical dissection and decrease operative risk. Now, there new technologies have arrived and are in the experimental phase like near-infrared autofluorescence by the parathyroid tissue, which helps us in localization. Then there are carbon nanoparticles, but these are experimental stage. We have used NIRAP in one or two cases, but we didn't find it so helpful. So the technology will definitely evolve. So these are the various the summary of the various imaging modalities which are used. The most common being ultrasound, sestomomy SPECT, and 4D CT. So what to do? Surgery remains the mainstay treatment. There are two main approaches: the conventional bilateral neck exploration, that is foreground exploration, or minimally invasive parathyroidectomy and unilateral exploration, based on the pre-operative imaging localization findings. So indications of parathyroidectomy is age less than 50 years, all symptomatic patients. Asymptomatic patients with calcium at least 1 milligram above the normal range, DEXA T score less than 2.5, lumbar spine, femoral neck, or distal babies, making them prone to have fractures, vertebral fractures, estimated GFR less than 60 ml per minute, urinary calcium excretion should be more, nephrolithiasis or nephrocalcinosis, and asymptomatic patients who want definitive surgical management and who cannot be on regular surveillance. So what are the goals of parathyroidectomy? Remove the abnormal parathyroid gland while preserving the normal gland, because we don't want the patient to land up into permanent hypoparathyroidism, because that is equally devastating. Treat associated thyroid disease and avoid complications. Intraoperative PTHSA, first game changer has been preoperative imaging, which helps us in localization which gland is at fault, and second is intraoperative parathyroid hormone assay, which helps us in understanding the completeness of the surgery. Now the parathormone half-life is less than 5 minutes. So there are various criteria like Miami criteria, Vienna, Rome, etc. These criteria. But normally which is being used is pH levels intraoperatively 10 minutes after excision of the parathyroid. So you do the pH before excision and then you do it 10 minutes after you excise. And if it is drop is more than 50%, then that means you have the curative resection has been achieved. So because of the imaging and because of intraoperative PTH monitoring, we have been like the focus or the mainstay of it remains minimally invasive parathyroidectomy. But in cases where you have expect multiglandular disease or there is familial history of Manning syndrome, Okay, when there is concomitant thyroid disorder, then you do bilateral neck exploration and four gland exploration, or in revision surgery, when the patient has undergone surgery and again is having recurrent hyperparathyroidism, then bilateral neck exploration with four gland exploration is done. So parathyroidectomy, cure after parathyroidectomy is defined as normal calcium more than 6 months after surgery. Okay, and PTH level, however, may fluctuate depending on multiple other factors. And the post-operative course again is the game of numbers. You see fluctuations of calcium, fluctuations of PTH, but calcium level should come to a baseline. So there is one very interesting thing which you find in post-operative hyperparathyroidism patients after surgery, that is known as hungry bone syndrome, which is rapid and prolonged hypocalcemia, hypophosphatemia, hypomagnesemia. That happens because now this stimulus, the parathormone is gone already, and the bones are osteoporotic, and whatever calcium is there, that is driven into bones, leading to hypocalcemia. So, it's reported in 25 to 90% of patients with radiological evidence of hyperparathyroid bone disease, and treatment is calcium, magnesium, and active metabolites of vitamin D. Now, outcome is defined more by calcium levels than by PTH levels. Persistent disease is defined as when serum calcium remains elevated after surgery or initially normalizes but becomes abnormally high again within 6 months of surgery. And recurrent disease is more than 6 months post-operatively if the calcium level rises, and it is known as recurrent disease. Now, benefits is whatever manifestations we have seen, cardiological, skeletal, renal manifestations, they are unfortunately reversible after surgery. Even this the new psychiatric symptoms also resolve with surgery. Reduced risk of fractures, and the risk of fractures does not resolve with does not come back to normal with the medical management. After surgery, they come to normal. Now, this is a very interesting paper which shows that even failure to diagnose hyperparathyroidism in patients with hypercalcemia. So, the interesting thing to note here is if you see the third row, the second column, serum calcium more than 10.5 milligrams. So, despite the serum calcium being more, IPTH, the PTH was not evaluated in almost 70% of the patients. So, that is where we have to catch. We have to understand, we have to make our physicians and our orthopedicians understand that when calcium is high, when we have a suspicion, we should try and get PTH done. So that we do not miss on these cases of hyperparathyroidism, then these skeletal manifestations or when these renal manifestations happen. Before we can catch them before these manifestations happen. So in this third row, second column, you see serum calcium more than 10.5 milligrams per deciliter. The number 10,432. Out of these 7,232, almost 70% were not evaluated, and out of which 844 were detected to have hyperparathyroidism. So the prevalence of undiagnosed and unrecognized primary hyperparathyroidism, in this study we have shown that out of the patients with hypercalcemia, 67% of patients never had PTH levels done, and 28% of whom were likely to have primary hyperparathyroidism. So with hypercalcemia, 43% of patients with hypercalcemia might turn out to have primary hyperparathyroidism also. So this is a common disorder, but under-treated and under-recognized. So under-recognition of the benefits of parathyroidectomy leads to underdiagnosis of the disease. Now in our case series, we have had 22 cases of parathyroid adenoma, age range 13 to 50, more common in females. 5 patients only had palpable neck swelling. And these were the skeletal manifestations, round cyst, bone legs, skeletal malformations which happened with bone cyst. They usually came to orthopedics department or endocrinology department and were referred to us. So this is how the various skeletal deformities that patients had. Hypercalcemia was in the range of 13.5 to as high as 18.2. Raised parathormone levels, elevated alkaline phosphatase because that is the bone turnover. We didn't have any case of familial hypercalcemia. Renal stone was seen in 6 patients, nephrocalcinosis in 3, and renal cyst in 3. 1 patient had acute necrotizing pancreatitis. 1 patient presented with hypercalcemic crisis, and inferior parathyroid was more commonly known than the superior parathyroid. So in this picture, the pointer is not working, but you see it is seen in the second row, the third and From the second plot, you can see from left thyroid gland, you can see a globule swelling beneath that. That is your parathyroid gland, which is a gold. So 4D CT, which shows a early venous washout. So you can see now this is the right side parathyroid gland. This shows the arrow shows the parathyroid adenoma. This is the cystometry scan showing the increased uptake in parathyroid adenoma in the neck, right side. This is how it looks like. Then the various skeletal changes also had the uptake, radio-based uptake. This is how the adenoma looks like. Though it is very small, but it leads to so many problems. So this is how it looks like after excision. This is again a big giant parathyroid adenoma which was excised. This is again, we had a series of 2 or 3 which were giant, more than 2 centimeter are known as giant parathyroid adenoma. So we had around 3 patients with giant. This was one which was giant parathyroid adenoma. So this is the relation to recurrent meningioma. So it is inferior parathyroid adenoma because it is anterior to the recurrent meningioma. So to conclude, primary hyperparathyroidism is a very important cause of reversible hypercalcemia, and it has a varied clinical presentation. Accurate early diagnosis and multidisciplinary management leads to optimal outcomes, and thorough knowledge of embryology and anatomy is required for successful surgery. And our aim should be to diagnose primary hyperparathyroidism cases early before the complications occur. So, belated Happy Doctors Day to all. Thank you.